I am a neurosurgeon, and we are transmitting live from here, Amman, from the Farah Medical Campus, Amman, Jordan. And the backdrop is the photo of the World Academy of Neurosurgery, in which I am. Topic for tonight is enterogenous cyst. What does that mean, enterogenous cyst? Entero means intestine. What does that mean? What does that mean in terms of what intestine cyst is doing in the brain? By definition, this is a benign, it's a congenital, malformative endodermal lesion. What does that mean? First described 1928 as teratomatous cyst of the spinal cord containing mucus and ciliated cells. This was reported in the Surgical Gynecology of such a journal back in 1928. 1934, it was reported in French, variety rare de teratome sous de rare de la région cervicale.
De la région cervicale.
Cervical intestinoma, so it's something related to the intestine. In 1979, the World Health Organization said that this enterogenous cyst is a cyst which is lined by mucin secreting epithelium, resembling that of gastrointestinal tract or bronchial tract. That's why it's a cyst that occurs in the CNS, but the lining of it is epithelium that is the same thing lining the gastrointestinal tract and the bronchial tract. 1993, enterogenous cyst classified as a tumor-like lesion. In 2007, no, it is not a tumor. In 2013, yes, it is. So there is how much confusion there is about this cyst. So if you look at the cyst tour, as we said, that the mucosa is respiratory mucosa, columnar ciliated, or gastrointestinal mucosa, columnar mucin. And the contents are creamy white, mucoid, pus-like, or thin clear fluid. So thin clear fluid, this is the cyst, and you can see through, so it is just full of something like water. This, just water-like contents, or this, before and after the surgery. Or it is full of something like mucoid. It's a mucus-like. Or it is full of something like pus-like, very much like pus. Or it is full of creamy white material.
Sterile?
Yes. Here it is, before and after surgery. So how come that these cysts that are lined by columnar ciliated epithelium from the gastrointestinal tract or respiratory reaches to the brain? So we have to look at the embryology. In the third week of your life, my life, and everybody's life, when the spermatozoa meets with the ovum, they divide and they form this. This is the amniotic fluid, this is the yolk sac, and here is where the life starts. So this is the amniotic sac, this is the yolk sac, and here is the ectoderm, here is the mesoderm, here is the endoderm. So this is the ectoderm, and from the ectoderm comes a layer called the neuroectoderm that goes in to form a tube. This will form the brain and the spinal cord. At the same time, something here called notochord is pushed back. So the neuroectoderm made a tube that will form the brain and the spinal cord. Notochord is pushed back. This is going to form the part of the spine. And here are the somites that will form the skeletal system. So this is the neural tube, this is the notochord, and these are the mesoderm that is going to form various parts of the body. This is real picture of a 4 weeks or 5 weeks fetus. So you can see the neural tube, the somites that's going to go form your muscles and skeletal system, and the notochord is pushed back. And here is the endoderm that is going to form your upper respiratory tract and your intestine. That's why this endoderm that's going to form the primitive gut. Primitive gut will form your lower respiratory tract and the rest of the intestine, esophagus, and the small intestine. So just like that, the ectoderm, the neural tube, and then here is the mesoderm. Okay, if the mesoderm cells stays in, so you will get something inside the neural tube, which is the brain and the spinal cord, and these cells will form these cysts. So this is the explanation. How do we get these cysts? So enterogenous cysts in general, they tend to occur in the mediastinum, in the abdomen, in the pelvis, or they could be limited to the brain tissue and spinal cord tissue, or there could be communication between the two. So that's why, or hence the names, the multiple names. People call it gastrogenous from the stomach, enterogenous intestine, foregut, of course, respiratory cyst, bronchogenic cyst, endodermal cyst, epithelial cyst, teratomatous cells, cysts, intestinoma. Now, the acceptable term in the brain or in the neural tissue is a neuroenteric or enteric cysts. Age, any age, but usually young adults, but cases reported from a newborn to 79, 80 years. Males are equal for 2 females, so there's no triple males. Lots of cases in the pediatric age group. This is one paper showing these cysts in a child. They are very rare, whether they are in the spine or in the brain. They constitute 1.3% of all spinal tumors and 0.2% of all intracranial tumors. And the spine is much, much more than the cranial. In the spine, they tend to occur anterior to the cord, and you can see the embryology why they occur anterior to the cord. They could be intradural extramedullary, or sometimes little percentage of these can be intramedullary inside the cord. And usually they are associated with some spine abnormality. Again, the embryology can give you the explanation. Why do we have these abnormalities? Abnormalities like scoliosis, all vertebral anomalies, hemivertebrae, etc., spina bifida, meningocele, dermal sinus, diastematomyelia, Klippel field, and syringomyelia. All these are associated with these spinal cysts. And people classify them into type A, type B, type C according to the epithelium. If it's single layer, we call it type A. If it is single layer plus mucous glands and others, it's type B. If it contains epidermal and glial cells, it's type C. They tend to occur in the lower cervical, upper thoracic, and as I said, it could be intradural or extramedullary or both. Examples in the literature, this paper about solitary cervical neuroenteric cyst, you can see it is anterior to the spinal cord. This is the spinal cord, and this is the cyst, and this is the histology. Again here, anterior to the spinal cord. You can see there pushing the cord backwards. Another case here, anterior to the cord. And this is the cord, and this is the cyst. The white is the cyst. The black is the cyst, and this is the cord. So anterior to the cord, this is the commonest type. Sometimes, as you said, you can see it associated with this anomaly. This is here the split cord syndrome, and it is associated, of course, this is the spina bifida here, so it is associated with these cysts. This is in the child again, that we have to remember that these diseases can occur in children, and they can occur with so many abnormalities in the chest and in the abdomen, whether it is dextrocardia or others. Other examples of these here in the lower cervical region, it is intramedullary, here intramedullary, and so on. So not only extramedullary, but also intramedullary. Again here another intramedullary one, reported in literature. And in the thoracic region, this is inside the cord, or in here, it is in the lower part of the cord, conus medullaris. Yes, of course. And this is one of my cases. And this young man Jordanian, 21-year-old with this huge anterogenital cyst inside the cord. There is just a little rim of cord left. And he was actually quadriparetic when he came. This is the cyst. We did the surgery for him and we evacuated it. So let's see the video, just to give you a sense of what we are dealing with. So here we are opening the dura, and this is the way to open it. 2 hands steady in the midline. And here we open the cyst, and as you said, you get this mucus-like or pus-like lesion. Okay. This is the histology, and another case. Again, it is intramedullary, and you can see it after we removed that as if the cord is split into half. Okay. Again, this is the way to open the dura. 2 hands steady in the midline so that you would not encroach on the right or the left. And then you open the arachnoid. And then you open the cord itself in the midline. These are stitches to hold the dura on both sides. And here is the so-called myelotomy, isn't it? Myelotomy, it's opening the posterior sulcus. And here I've got hold of the cyst itself, trying to remove as much as I can. The idea is that you evacuate the contents, but if you can remove the capsule, that would be fine, if you can. It can recur. If you don't remove it completely, it can recur. So here we are removing the wall from inside the cord. Okay. So we spoke about spinal group. Let's speak about the intracranial group. All in all, 80 cases reported inside the brain, and mostly they are infratentorial in the posterior fossa. And when they occur in the posterior fossa, they are also anterior to the brainstem. But they could be in the cerebellobentine angle, they could be anterior to the cervical junction, or they even go to the fourth ventricle. Examples: this is ventral to the brainstem. This is from USA. Another paper from UK. Look at this. You would think this is arachnoid cyst, but still it needs to be removed because it's causing so much pressure. From India, and they are very good in reporting and literature. We in the Arab world are very weak. We don't publish, very, very little papers published, and we encourage always publication. But this is, again, you can see the region from China. Again from China. From Japan. And the good word of neurosurgery, you cannot progress from one year to the other unless you produce some papers. It should be in every discipline of medicine or surgery. Again, this is a ventral lesion to the medulla and to the spinal cord at the foramen magnum. Another paper here with this extensive tumor from Michael McDermott from California. He's basically a meningioma man, but he's a good surgeon. San Francisco. China, again, another paper. You can see there, another paper. This is William Caldwell. He's from Utah, Salt Lake City. He is the president of the ANS. He's a close friend of mine. And this is one of his papers showing this cyst. And this is the approach. Another case, ventral to the cord and the brainstem from Japan. This cyst there. Again, histologically proved. All of these have been operated from Italy. Again, you can see from UK. Now, we are speaking about dorsally located, not in front of the brainstem, but back on the fourth ventricle or in the cerebellum itself. Here it's occurring at the quadrigeminal cistern, so it is back. So it can occur back to the brainstem or anterior to the brainstem. Here is the commonest. Again, cyst that looks like intrinsic tumor from China. From India, they showed this as extradural, not intradural. And you have to remember that they are full of this crayony material and they can cause meningitis. So they cause chemical meningitis. And it is fulminant like any bacterial meningitis. Supratentorial, as you said, it is less than the infratentorial. Above the posterior fossa is less. And they can occur in any of these sites. Only 22 cases reported. And our case is the 23rd. This is the lesion. And one would say how this lesion arrived here. Was talking about spinal cord formation and the notochord and the neural tube. Neural tube starts from the dorsum celli down to the sacrum. What about these lesions happening, supratentorial ones? It comes to this explanation. We did explain this in a previous lecture about Rathke's pouch, and we said there is a pouch that comes from the pharynx, meeting a pouch coming from the brain tissue, and they would meet and form the pituitary. But sometimes some of the cells remain the endoderm, and these would cause Rathke. So this is the explanation why we get these supratentorial ones. To the point that people would say colloid cysts and Rathke cysts and enterogenous cysts are the same. They are the same pathology. Pictures of these supratentorial ones. All supratentorial. So again, we may visit this as arachnoid cyst. Or intraparenchymal, inside the brain tissue itself. This is from Atul Gul. Atul Gul is one of the famous Indian neurosurgeons. He is a brilliant man. He is considered to be the most experienced in the foramen magnum area. Again, he was here a few months ago. They can occur in the orbit, and they can occur in the lateral ventricle and third ventricle. Here's in the third ventricle. And here is within the third ventricle too. This is a very unique case of enterogenous cyst affecting the oculomotor nerve. Oculomotor arises from here, from the medial to the crus cerebri, interpeduncular cistern, and goes this way to the cavernous sinus. And here is the cyst that is affecting the third nerve. Again, here, third nerve. This is reported by Charles Tu from Australia. He's an endoscopic man. It could be multiple, like this.
Multiple.
And again, this is a paper from Australia, from Andrew Kay, from Melbourne. I don't know, Muhammad Jalad is here. Muhammad Jalad trained with Andrew Kay, who is a friend of us, of Jordan and myself. And he has reported these cases of the supratentorial cysts. It could be infratentorial. We were just saying about this paper, Muhammad, reported by Andrew Kay about these supratentorial things, and we said that you trained under his care. So they could be, as I said, supratentorial and infratentorial. So what is the treatment? Surgery. There's no chemotherapy, no therapy, no antibiotics, nothing. Just surgery. You have to do surgery. And you have to remove the contents and try to remove as much of the wall, like this. No radio, no chemotherapy. They can recur, yes, some cases are reported, as Marwan mentioned. Again, here is another occurrence in this case. Sometimes the capsule is adherent to the brainstem tissue that you cannot remove it, and this may be the cause of recurrence, but usually it takes many years for it to recur. Again, this was operated on 3 times. This is from India, and this is from Hong Kong again. They removed it recurred, they removed it recurred again. So there are cases with recurrence. Can they turn malignant? The answer is yes. 4 cases are reported of malignant change happening in these enterogenous cysts. That's why if we say that this is not a tumor, it is a tumor and it can turn to be malignant. Just like an epidermoid. People are still speaking about epidermoid cyst. It is epidermoid tumor. And enterogenous cyst, we have to stop saying cyst. It is enterogenous tumor. So these are proved cases of malignant change within these enterogenous tumors. Many cases reported, 4 cases. So we come to our case. I'm sorry, I've become cold. We'll present one of our cases. This is a 30-year-old male patient coming from Bahrain. This is very recent admission. It is here at Farah Hospital. And he just complained of headaches for many years, diagnosed as whatever. In the past history, he has glucose 6-phosphate dehydrogenase problem, sickle cell trait. He had sinoscopy and gastroscopy. He's a stressed person. General examination was well. Vital signs were okay. Neuro examination was normal. No cerebral signs. This is to show you that his facial functions are okay. We're seeing the lower face and we are seeing the upper face. This means that facial functions are okay. Show you here that he's elevating his arms, so he does not have weakness, pyramidal weakness. And here we're looking at his eye movements, saying that he does not have eye movements. So he just has headaches. Again, ophthalmology was okay. No weakness in his upper or lower limbs. CBC was normal. Liver functions, normal. Kidney functions. These are his results, so they were normal. Let's look at his images. Basically, in general, there is no pattern of image for these cases because it depends on the contents of the cyst or the tumor, whether it is clear fluids or mucky fluid or crepey fluid. So that would reflect on the image. So you can, in the CT, have hypo, iso, or even hyper. But usually there are no calcifications. And in the MRI, typically T1, iso, hypo, hyper, T2, iso, hyper. So there's no pattern. It is just by suspicion. I'm here putting the report that came with this man from Bahrain. It's made of 3 pages. And I would love to see this happening in Jordan instead of the 3-4 lines that we write. The radiologist has the responsibility to guide me towards the diagnosis. It is not just to describe what he is seeing. He must come to the conclusion, what could that be? And if he cannot pinpoint the diagnosis, he at least will give me a good differential diagnosis. So this is a very well written report. And by the way, it is written by one of the Indian radiologists working in Bahrain. This is the 2nd page and the 3rd page describing. He is here saying this is epidermoid cyst, may be considered, but this also could be a neuroenteric cyst or even a proteinaceous cystic schwannomas. It's a very brilliant kind of thinking. So these are the images. You can see that we have this lesion in the front of the medulla. So it's a pre-medullary lesions. Here it is in all the sequences. Here's with contrast, so there's no contrast.
So what was your first impression?
You can ask my assistants and my colleagues, Dr. Muhammad Jalad, my colleague, or Dr. Misa. I was thinking of a neuroenteric cyst. I was thinking of epidermoid. I was thinking of a schwannoma, cystic schwannoma. Yeah. It's important because you want to plan your action. So again, there's no contrast enhancement. This is high definition T2. You can see the medulla oblongata. You can see the tonsils, the flocculus, and you can see the lesion. And this is the vertebral artery. So this is a very hideous place to hide. Again, you can see it here. And again, in the board exam, I would put something like this. What is this structure? And the candidate would say, this is midbrain. He just cannot pass. If he cannot realize medulla from pons from midbrain, he should fail miserably. Again, you can see the lesion in various high definition T2. Again, I would ask, what is this? And he would say, this is internal acoustic neuroma, internal acoustic canal. Again, another picture of T2, you can see the lesion, anterior to the medulla. This is fourth ventricle, this is the lateral recess, here is foramen of Luschka, and this is flocculus. So the lesion is there. So you know that this lesion is lying anterior to the medulla, related to the vertebral artery. It's difficult to reach. Here it is. Here we are looking and seeing the arteries, carotid artery, etc. Here we are looking at the restriction. There's very little restriction. It's not a major one. So you may say very little restriction or no restriction. And restriction here would have pointed towards epidermoid. Again, here we can look at some of the vessels surrounding it. Here is the internal carotid artery. This is the petrous carotid, etc. And again, if you put such a picture and ask the candidate what are these, and he would not know, he should not pass. This is coronal view, vertebral artery on the right, vertebral artery on the left. They will meet here at this point, which is the junction between the pons and the medulla. So it is straddling the vertebral artery. Here it is. So this is pons, this is midbrain, pons, and medulla. And again, people speak about brainstem. It's wrong. Brainstem is 3 continents. 3 قارات. The continent of midbrain, the continent of pons, and the continent of medulla. So you just cannot summarize it and say brainstem. Here it is. Medulla, pons. It is at the junction. Here's the basilar artery. This is vertebral artery. So it is intimately related to the vertebral artery. We did CT to see whether there's any bony abnormalities. There's nothing. No bony erosion. Because this could be a sort of a bony lesion. Again, in the coronal, you can see the interdictory hiatus, you can see the joints, everything. We did angiogram to see the vertebral artery, especially the right one. There it is. We need to see the whole length of the vertebral artery. If we are keen on operating on this patient, the left vertebral artery and the MRA. Here is MRA. This is carotid, of course. This is carotid, vertebral, and this is the vessels. Rather good MRA. And rather good MRB. I need to know all these inferiors. Sagittal sinus and the internal cerebral veins and vena procentale, state sinus. I need to know all about these. But look at this. Again, the problem of the radiology technician. Our technicians are not observed by our radiologists. They do whatever they like. They are not supervised. Can anybody tell me what is the value of these? Why are you omitting these areas? Because he was told, and he would take the pen on the computer and just do this without any knowledge why he is doing this. You are hiding information from me. You just cannot do this. So I am looking for the day when these technicians are hit hard on the head to know that they have a job to do. And their job is to consult with their radiologist to see whether they have done the right job or not. Especially when we talk about قطاع عام. Medina, Jama, al-Akhiri, where people would take the appointment after 6 months. And if the picture is not good, they have to wait for another 6 months. Look at this. Why are you doing this? Why are you hiding? I have no idea. We have said this many times before. So what's the differential diagnosis of this lesion? It's extensive again. We are talking about cyst in the central nervous system. Epidermoid, dermoid, choroidal, ependymal from the ependyma, Rathke, colloid, parasitic, cystic tumors, etc., etc. Again, we have to think what is this lesion. This is cystic schwannoma. This is grade 2 astrocytoma, atypical territory, epidermoid and dermoid. This is cholesterol cyst and arachnoid. All these should go into differential diagnosis: brain abscess, tuberculous abscess, vasculitis, cysticercosis. Muntasar is here?
Yeah.
So
Yes.
again, is this fancy diagnosis?
It is a fancy diagnosis. We don't see much of it here, but
But it is common in other places.
in other places in the world.
Absolutely. So we did a few consultations. Dr. Muhammad Jum'a was consulted to see the patient in general assistant. Any words, Muhammad?
Yes, actually, he is medically free, and
Yes.
I was not able to find any system disease. And I gave the clearance for
For
surgery.
the surgery. Thanks. We asked Dr. Walid Sarhan, our psychiatrist, to see him, as we do with most of the patients with brain surgery. It is a must that they should be assessed from the psychiatric point of view. He and his assistants, Hala al-Bishtawi, they did this. They give us a score. So they scored this mild, high score on anxiety and depression. So he's mildly depressed, and Whistler number scale was good within the range. Karnofsky performance scale was good. So the clinical impression was that this man has a mild anxiety depression, and he has been on irregular treatment for the last 2 years in Bahrain. This is very important for us. Surgery is a stress, and if you don't know what is the psychiatric condition of the patient before surgery, you will be shocked to see different personalities after surgery. Anesthesia, Dr. Firas, would you like to? Yes, yes.
Assalamu alaikum. My name is Dr. Firas. I'm a sociologist. I was to see this patient. But first of all, I would like to, again, we can't thank Dr. Ibrahim enough for these kind of meetings. Because to us anesthesiologists, it reinforces two very important concepts. The first one is the concept of perioperative medicine, as now it is a well-established subspecialty and a branch of anesthesia. And the second one is the concept of multidisciplinary meeting, as we learned so much from Dr. Ibrahim's cases since I was a resident. And these two concepts, again, reinforce the concept that good medicine is an expensive medicine, wherever you go, whether in the private sector or in the public sector. So tonight I'll be discussing a very important topic from an anesthetic point of view, even though it's a purely hematologic problem, but it's extremely important to us anesthesiologists. And unfortunately, these two subjects are underestimated of how it can be fatal if the patient is not well taken care of. So the first problem that the patient had is the G6PD deficiency, or the glucose 6-phosphate dehydrogenase enzyme deficiency, and he had a sickle cell trait. So we'll be discussing them from an anesthetic point of view, and hopefully Dr. Ala will have some comments afterwards. So just briefly, as an introduction, the glucose 6-phosphate dehydrogenase deficiency is the most common enzymatic disorder of red blood cells in humans. It is estimated that there are 400 million people around the world affected by this deficiency. The G6PD deficiency is an excellent recessive disease caused by deficiency of an enzyme in the hexose monophosphate pathway shunt. And this is extremely important in terms of biochemistry, and we'll see later on how it could affect us in a negative way extremely badly if the patients are not well taken care of, especially in terms of how this patient is going to handle the stress of surgery, especially it's a very long procedure. And this results in decreased production of nicotinamide adenine dinucleotide phosphate or hydrogenase, simply NADPH. And the inheritance of G6PD deficiency shows a typical X-linked pattern with higher incidence in males than in females. These two figures, actually, just to give you a little bit of a summary. So this is the pentose phosphate pathway, and it's linked to glycolysis process. First of all, we have the glucose, which is transferred to glucose 6-phosphate oxidative process, and this is gonna produce 2 NADPH and CO2, and this is an irreversible reaction. This is extremely important to our biological processes, especially for fatty acid synthesis. Glutathione reduction, which is extremely important to see how our red blood cells will handle stress, especially during periods of stress, in terms of, for example, infection, surgery, and so on. So okay, no. So if we, sorry, go back to the figures. So if we look at this, when oxygen actually binds to hemoglobin, it's in the ferrous state. But in case of methemoglobin, it's in the ferric state. So the hemoglobin is unable to unload oxygen, so the tissues will not be able to actually make use of oxygen. In addition, we have the superoxide anion, which produced by the superoxide dismutase. It produces hydrogen peroxide, which is extremely bad for the cells. And this is tackled through the glutathione reductase via the G6PD, via producing NADPH, and to produce the reduced form of glutathione, which will enable our bodies to get rid of all these oxygen radicals. Most cells have a backup system for other metabolic pathways that can generate the intracellular NADPH necessary. But on the other hand, the red blood cells do not have the NADPH producers. Therefore, G6PD deficiency becomes especially lethal in red blood cells, where any oxidative stress, especially at time of infection, this is extremely important to us in the perioperative period, in cases of infection, and in terms of handling the stress of surgery. And it will result in hemolytic anemia. So oxidative stresses can arise again from numerous things, such as consumption of fava beans, اللي هو مرض التفاعل, certain drugs. This specific patient has been banned from eating all kinds of beans. Certain drugs, infections, and certain metabolic conditions, such as diabetic ketoacidosis. So just again to reiterate that the typical form of red blood cells, it contains what is called Heinz bodies. This is a sign of denaturation of hemoglobin at the time of stress when we have G6PD deficiency. According to the World Health Organization, the classes of G6PD, it's classified into 5 classes, from class 1, which is severely deficient, to class 5, which is more than 150% of increased activity of G6PD. So what's the clinical implication? And this is very important, not only to us anesthesiologists, but also for doctors in the world who are involved in the care of this very specific patient and patients with G6PD in general. Every healthcare provider has to be cautious in managing G6PD deficient patients, as inadequate management of those patients who develop acute hemolytic anemia can lead to permanent neurologic damage or death. So to us anesthesiologists, and for all doctors involved in the care of G6PD deficient patients, they should be aware of number of drugs that can precipitate hemolysis in these patients. So this table just gives a summary, and by the way, this is not the full complete list, but it's just a summary of the most commonly used drugs. It's classified into unsafe drugs and safe drugs for class 2 and 3. As you can see, dapsone, methylene blue, which is used very much especially in the OR. Phenytoin is again, and all the sulfa drugs. Save for class 2 and 3 patients, for example, acetaminophen, and this is very important because some patients it's very unsafe to give acetaminophen, but our patient was actually, he had previous exposure to acetaminophen, and it was very safe to give him acetaminophen. These drugs can interact with hemoglobin and oxygen, leading to the intracellular formation of hydrogen peroxide, as we mentioned in the figure before, and other oxidizing radicals. As these oxidants accumulate within the enzyme-deficient cells, hemoglobin and other proteins are oxidized, leading to loss of function and cell death. What about anesthetic drugs? Altikat et al. Studied the effects of certain anesthetic drugs such as halothane, isoflurane, and so on. What they found is that although isoflurane and sevoflurane, which is anesthetic gases, but also some benzodiazepines such as diazepam, midazolam, had an inhibitory effect on the G6PD activity in vitro, while halothane, ketamine, and prilocaine had none. Even though in vivo, actually, it had the contrary results, as no documented cases were found to show that benzodiazepines, codeine, propofol, fentanyl, which we use very much in the anesthetic drugs as part of the anesthetic management, fentanyl or ketamine can cause hemolytic crisis in G6PD deficient patients. And generally speaking, most of the anesthetic drugs are extremely safe while dealing with G6PD patients. Apart from prilocaine, which is contraindicated as it might cause methemoglobinemia. So general anesthesia typically masks the immediate signs of hemolysis, making it very difficult to identify a hemolytic crisis while the patient is asleep. And our patient was in the sitting position, and it's a very prolonged procedure. So extreme vigilance and meticulous care should be taken care of throughout the procedure. Even hypotension, which could be a result of hemolysis, may be attributed to other causes in an anesthetized patient. So the differential diagnosis is wide when we have hypotension intraoperatively. The appearance of free hemoglobin in plasma or urine is presumptive evidence of hemolytic reaction. That's why, again, to reiterate the importance of a urinary catheter during prolonged procedures for these patients. So treatment consists of discontinuation of the offending agent and maintenance of urine output by infusion of crystalloid solutions and diuretics such as mannitol or furosemide. Again, for the staff who are taking care of these patients post-operatively, whether in the ICU or in the ward, the G6PD patient can present certain clinical manifestations that may trigger the need for additional support or treatment. In general, hemolysis is seen 1 to 3 days after contact with the triggering factors, so it's not necessarily that it has to be immediate. And acute hemolysis is usually, in most cases, self-limited, but in rare cases, it can be severe enough to warrant a blood transfusion. So what are the clinical signs and symptoms? These patients might develop cyanosis, headache, fatigue, tachycardia, dyspnea, lethargy, even lumbar or substernal pain, which is atypical signs. Abdominal pain, splenomegaly, hemoglobinuria, and scleral icterus. Also, the breakdown products of hemoglobin will accumulate in the blood, causing jaundice, and they can be excreted in the urine, causing dark brown discoloration of the stool. So what investigation should we order when faced with these signs and symptoms of hemolysis? So what is advised right now is to do a complete blood count, which we might find anemia, reticulocytes count, which might show an increase by day 4 to 7. Peripheral blood smear, which might show Heinz bodies, as we have shown in the previous figure. Haptoglobin, which is decreased in terms of hemolytic crisis. Liver function tests will show elevated bilirubin. And by the way, this patient had elevated direct bilirubin, indicating a chronic hemolytic process, which was very minor. Urine analysis, which might show brown discoloration and hemosiderin. And most importantly, the lactate dehydrogenase, which can be extremely elevated in case of hemolysis. So what anesthetic considerations, just to sum up? In case of chronic hemolysis, chronic packed RBCs transfusion, which patients would give you a history, difficulty in cross-matching these patients and anemia. Other considerations for us anesthesiologists is avoidance of any oxidative stress as it might precipitate acute hemolysis, such as oxidative drugs as we've shown in the table before. Infection, hypoxia, hypothermia, and stress should be all avoided intraoperatively. Metabolic abnormalities, such as very high blood sugar, and foods before the operation, of course, for example, fava beans. Unable to reduce methemoglobin, for example, methemoglobinemia and methylene blue are contraindicated. And we should consider a hematology consultation if the case is severe.
Or it becomes severe.
Absolutely. So what are the goals for us anesthesiologists? Identifying patients at risk, avoiding precipitating oxidative stress, as we said, and manage hemolysis by removing the trigger and packed RBCs transfusion if needed and supportive management. Common drugs, as we said, to avoid acetaminophen, acetylsalicylic acid, and in terms of antibiotics, ciprofloxacin, methylene blue, and phenytoin as an anti-epileptic. And this is very important during neurosurgery. Okay, I'll just talk briefly about the sickle cell trait, and bear with me just for a few minutes. The sickle cell disease is a hereditary hemoglobinopathy resulting from inheritance of a mutant version of the beta globin gene on chromosome 11, and the gene that codes for the assembly of the beta globin chains of protein hemoglobin A. The mutant allele S codes for the production of variant hemoglobin, which is the hemoglobin S. The heterozygous carrier state is known as sickle cell trait, results in a production of both hemoglobin A and S, and has a predominantly benign clinical picture. But this could be very deceiving in some patients, and we'll see why. So this is just the table to summarize the hemoglobin mutations associated with this syndrome, and as we said in the thalassemia trait, it's hemoglobin A and S. So just briefly about the sickle trait that our patient had. The sickle cell trait usually is not regarded as a disease state because it has complications that are either uncommon or mild, but we could be faced with it. Nevertheless, under unusual circumstances, serious morbidity and mortality can result from complications related to polymerization of deoxyhemoglobin S. And clinically, it cannot be differentiated from sickle cell disease crisis. Such problems include increased urinary tract infection in women, gross hematuria, complications of hyphemia, splenic infarction with high altitude hypoxia, and that's why hypoxia intraoperatively might precipitate acute hemolytic crisis, and very severe exercise. And how this is reflected into handling the stress intraoperatively, no clear or strong evidence as yet, and hopefully furthermore studies will be done to see how the sickle cell trait patients would behave under stress, especially under surgery. And life-threatening complications of exercise and idiopathic sudden death. So a summary of risks associated with sickle cell trait can be summarized as follows: splenic infarction, hematuria secondary to renal papillary necrosis, fatal exertional heat illness with exercise, sudden idiopathic death with exercise. How could this can be translated to see how these patients behave under surgery? This remains to be elucidated. Glaucoma or recurrent hyphemia following first episode of hyphemia, bacteriuria in women, bacteriuria and polynephritis associated with pregnancy, and renal medullary carcinoma, and early onset of end-stage renal disease. So what are the goals for us anesthesiologists? Most importantly, to avoid hypoxia, vascular stasis, hypothermia, hypovolemia, and hypotension, and acidosis, and to optimize perioperative pain control. And thank you very much.
No, we've not these results with him. Is this by hemoglobin electrophoresis or was this genetic?
He was actually plasmapheresis and was done in Bahrain. He was diagnosed, as far as I know, 15 years ago. So that's why he was already diagnosed when he came to Jordan. So we presume that he is a G6PD deficiency.
The sickle cell trait was this guy.
Yeah, it was diagnosed in Bahrain as well.
Now, sickle cell, if he has trait, it should not be hemolyzing. But if he actually had high indirect bilirubin, this is really concerning. And nobody with G6PD trait should come to you with high indirect bilirubin. They need facts that
No, he had a G6PD deficiency, but he had a sickle cell trait. Yeah,
sickle cell trait
Yes.
is not cause.
absolutely.
Now, the G6PD deficiency,
Mhm.
if he has high indirect bilirubin, no matter how, even if the elevation is not high enough, this is really concerning.
Absolutely.
Extremely concerning. The fact that it's been there, it's chronic. This is exactly the kind of scenario where I would worry the patient would really deteriorate during surgery because of the extra stress.
That's what
Now, when we were in medical school before differentiating into oncology, we had in our pockets the whole list of potential interactions in G6PD deficient patients. We're living in a part of the world where G6PD deficiency is extremely common in comparison to other parts of the world. You really have to know every single thing that you might try that no computer system will detect as a contraindication when you're writing this. As this patient is coming to you with high bilirubin, even if that is not I don't need a very high bilirubin to make me concerned. The slightest increase in indirect bilirubin to me is concerning enough.
Unless it's a Gilbert's in addition.
It might be, but we presume that he is a G6PD
So
deficient.
this is
an
updated hemolysis. So somebody who's coming into surgery with knowing what to avoid, and he is already in a level of hemolysis. That's actually quite concerning.
So it's not only the location of the lesion is difficult, he is a difficult patient. Yes, please. Sorry? Just the fact that he is a smoker. I say everything, I put everything in the. No, let's do that, please. Of course.
As a radiologist, the typical appearance for the introduced in T1, it is hyper. In T2, 90% hyper, 10% hypo. Okay, this is the appearance of the. On the CT, you can't know, as Dr. Ibrahim said. For the diffusion images, always when I look for the diffusion, I should have ADC images near to it, because shine through may be seen as hyper in diffusion, so I have to put the ADC near to it. If it is high in ADC, this is not diffusion. It is low in ADC, this is in diffusion. Okay? There are other things. You don't have to do the CTA and MRA for the patient pre-op. You have to choose one. Are you interested in the deviation, obstruction, or you are interested in narrowing or atheromatous changes? So for this patient, I think MRA was enough for evaluation, neck MRA and the brain MRA. The last point that Dr. Ibrahim, when he showed us some images, and he said that this is the medulla and this is the lesion, and this is called Cysts images. These Cysts images, you see the CSF as hyper and the whole tissues as hypo. You can't differentiate inside the lesion or inside the normal tissue for this signal. It is good to show you the outline, but it is not good to characterize the lesion. Thank you.
Absolutely right.
Thank you.
Okay, so we got the consent, as you can see, the usual consent that we speak about complications, 10%, and we explain what 10% means, that 10% out of each 100 patients having the same procedure would have complications, and these include, but not exclusively, whatever. We mentioned ibuba, and we mentioned death. Posterior fossa is a killer surgery. So, speak about some anatomy. We are actually here, junction between medulla and pons. It's anterior. So I have to vision where exactly the lesion is. So again, this is the basilar artery. basilar artery, two vertebrae. So the lesion is on the right side and it is tucked here. And important microphone, is the anterospinal artery coming from the vertebra. So we are going here in this area. This is a true cadaveric specimen. I attended, even as a consultant, many cadaveric courses. This is one course I attended in Gainesville in Florida with Professor there, and this is the specimen that I worked at. This is the brainstem, this is the vertebral meeting the other vertebral to form the basilar. So I'm working here. I need to visualize all this. Vertebral, basilar. The lesion is here. There. With all these nerves, this is the internal determinatus of an eighth. This is jugular foramen. Glossopharyngeal as a single fiber, vagus as multiple fibers, and the accessory nerve coming from cranial part and spinal part, and the hypoglossal. So again, so many nerves there, and the medulla itself. We do this in the sitting position, as we mentioned many times, and we are going to this part on the right side. So there we are. We will meet all these structures. The spinal cord, the medulla, the vertebral artery, the pica, the accessory nerve, the C2, C3 roots, and all of the cranial nerves there, on the right and on the left. So let's see the surgery. Again, it's a short, life-shortening kind of surgery. Here we're at the level of the foramen magnum, because as you have seen on the pictures, I'm opening here the arachnoid, the lesion is related to the vertebra. So my first aim is to see the vertebra. We are opening the arachnoid, and this structure is the accessory, spinal accessory. Goes like this, join the cranial accessory. So the vertebra is here, and this nerve is the hypoglossal. Now I'm cutting the dentate ligament, so that if I need to rotate the brainstem and the spinal cord, I can. Again, medulla oblongata, pica, accessory nerve. Now here, again, the accessory nerve.
Did you use magnification in this case?
The microscope gives you 15 times magnification. So this is the hypoglossal nerve.
Magnification.
No, I did not. No. So I'm seeing the lesion now. Myself and my associate, Dr. Muhammad Jalad, were thinking, where is the lesion? Because as we lifted the cerebellum, it went up with us. So I'm opening it.
White pad, right?
This white thing, yes. And you can see some material coming out. This is the vagus nerve here. So we start removing it. Now we are inside the so-called cyst. I'd like to stay within the capsule so that I will not damage any of the neurovascular structures. Thick, creamy material, as you can see.
So you didn't aspirate it? Just
No,
basically-
no. Even if you try, it will not be aspirated because it will clog the needle. Even the sucker is not able to take it out. So vagus is here. If you damage that, you will have vocal cord paralysis, you will be ending on a ventilator. This is the medulla that we are pushing this way. So most of the contents are out. This is not enough. We have to look for the membrane. We have to look for the capsule and try to remove as much as we can. You can see the pulsations of the brain. This is the vagus. We'll see it now. So this is the accessory spinal and cranial. This is the vagus made of many filaments, and the one above is the glossopharyngeal. And this is ICA going to the facial nerve. ICA, we have seen it before. ICA is related to the lower cranial nerves. Surgery is finished. No retraction on the cerebellum because we drained CSF. So you can see just taking the retractor out, the cerebellum would just fall back. This is the medulla, this is pica, these are the nerves that we have mentioned.
Were you able to get the capsule out?
Yes, most of it, I would not say totally, because it is, here is the vertebral, that's the vertebral, so it was attached to it. This is the hypoglossal nerve. And these are the three nerves, glossopharyngeal, vagus, and accessory, going to the anterojugular foramen. And this is the pica. Pica is related to these, ICA is related to the facial. Okay. So, histology.
This case was sent for frozen section. I thought this is what I received the frozen section. I thought I called it consistent with epidermoid cyst or tumor. You can see these are keratinous cysts. But looking at the growth or the surgery, that's why surgery is very important. It's different from actually the epidermoid tumor, where it's barely or bear-like pattern of configuration. هذه كانت more like proteinaceous يعني cystic. فأعتقد يعني it was not right الماتيريال الأولانية. This is when I saw I did something like this, I thought this is, I did not see a lining epithelium in the frozen section. I see only the material. I saw the keratinous material, so I thought this is epidermoid. But I will show you why it has keratinous material and it mimic epidermoid cyst or tumor. This is the final or the tumor where we received it in permanent. You can see this is the lining epithelium. Many things. I will show you how thin is the wall, and very, very delicate. All this is the wall, is microns. This than one in 1 microns of the millimeter. And you can see different cells lining the wall. يعني هنا في stratified squamous epithelium. هنا بتحول in some areas ciliated pseudo-stratified columnar epithelium. Other areas columnar epithelium. I will show you different areas. فهنا this is not the lining of the epidermoid tumor. This is different. نشوف I will show you different types of the wall. Very thin wall and very different lining epithelium. راح ندخل على higher power. Very typically they have the cilia, and this is طبعا is not there in the epidermoid. These are foamy macrophages indicating this is cystic structure. When we see something like this, we know cystic. But here is this stratified squamous when there is here is pseudo-stratified columnar with cilia, and here very simple pseudo-ciliated epithelium, much thinner wall, 2 to 3 cell layers maximum. Again here different types. حقيقة I took many pictures of this neuroenteric cyst because this is the first time that we see it. So I want anything that's rare. I usually take many pictures because probably will someday will publish it. And the typical location for a neuroenteric cyst is usually anterior to the medulla. This is one of the most common location. خليني أوريكم this is the material. هذا cyst is producing this material. راح تشوف هلا الماتيريال is really 2 components. هنا proteinaceous like material. هنا this is ciliated epithelium. خلينا نشوف other areas. هنا الماتيريال شايف هنا is 2 components مع أخذت البيكتشرز interface with each other. هنا الكيراتينس material. You can see الكيراتينس and هنا colloid like material or proteinaceous material. عشان هيك الكولويد cyst تدخل بالديفرنشال. هنا mostly the colloid material. So you can see the pattern of 2 different materials. It depends on the lining of the epithelium. إذا كانت جاي على lining of squamous stratified squamous بتطلع لنا السكويموس areas. إذا كان على السيلياتد كولومنر بتطلع الكولويد areas. هنا again I want to show you the keratinous material اللي اجت معي على الفروزن. There was no lining. You can see these are squamous cells and هنا الانترفيس هنا squamous cells هنا الcolloid proteinaceous material. So many different components of the same cyst. عشان هيك شفتوا هنا again أنا شفت أخذت good pictures. هنا squamous هنا colloid material different. هنا colloid material or mucoid material اللي شفتوها بيسحبها الدكتور ابراهيم. هنا السكويموس هنا تشبه كثير الابيديرمويد cyst. هنا again you can see هنا مثلا عشان السكويموس lining هنا بتشوف السكويموس بنفس الاتجاه. هنا لا الكولويد you can see الكولويد material هون. هنا جنبها في squamous part here. This is a BS stain. BS stain stains الميوسين عندنا BAS stain. And this is usually there is goblet cells, neuroenteric cyst or enterogenous cyst. You expect to see goblet cells. This was a rare goblet cells, يعني مش many of them. لكن I wanted to show to you when you see something like this. طبعا this is important. And I took picture of it and it was very nice to see it. And this is a BS material to show you that the content of the epithelium, most of it, the content is mucoid, يعني BS positive material. You can see some cilia برضو stands with the BS material. هنا this is CEA. CEA is positive in things that are producing. It stands for carcinoid break antigen producing mucin, and you can see the lining is negative, but the contents are positive. For indicating this is part of the neuroenteric cyst. The villain is another marker. It's used in the enterogenous areas or GI. It was negative in this case. Usually when there is mucin production, they are positive. High molecular weight cytokeratin, we did many cytokeratins. High molecular weight stains in the basal cell layer, and this is the multiple layers. This is higher power to show you how the superficial layer is negative while the basal layer is positive. Cytokeratin 5-6 is positive in the basal layer. Cytokeratin 7 is positive in the superficial layer. The contents on the superficial layer is different from cytokeratin, high molecular weight cytokeratin. And this is again cytokeratin 7 positive in the superficial layer. Cytokeratin 19. This is very important. Cytokeratin 19 احنا عندنا حقيقة discovery من الحالات اللي بنعملها إنه cytokeratin 19 is positive in almost all brain cyst tumors. حتى ودينا publication للكوليج اوف امريكان باثولوجيست على أهمية using cytokeratin 19 to identify brain cyst tumors. أنا والدكتور إبراهيم على الحالات اللي عندنا the different tumors, colloid cyst, Rathke's cleft cyst, dermoid cyst, and ما كانش موجودة هاي الحالة حقيقة craniopharyngioma. ما كان موجودة هاي الحالة. بعد ما بعتها أجت هاي الحالة اللي هي neuroenteric cyst. And this is the positivity of neuroenteric cyst. بس بدي أعطيكم فكرة عن cytokeratin 19 why it is positive. حقيقة أنا بحثت بالليترشر why it is so consistent إنه عن جد كل brain cyst عندها cytokeratin 19. Cytokeratin 19 is a 40 kb molecular weight, and it is present in the embryo at the periderm. ما أعتقد حدا فيكم سمع بالبيريديرم قبل هيك. البيريديرم arises from the neuroectoderm tissue, and it's from the superficial layer of the epidermis transiently من month 1 to month 2 بالembryo. بعدها بتكون السكين وغيره. To me, why I'm interested in this, it looks like all, and this is what hypothesis I have hypothesizing, and most probably or all the cysts in the brain are probably present from the periderm and neurologically, and because they don't mature enough, we still have the evidence of periderm origin. That's why the cytokeratin 19 is positive. We send this to publication or the presentation as abstract. النتيجة راح تيجي بشهر 6 إن شاء الله بنخبركم عنها. Maybe at one time we'll talk more about cytokeratin 19. But this was very interesting finding. In finding again I took many pictures because of cytokeratin-19 and the stains الغريبة مش one layer, all layers يعني deep layer and superficial layer. Not only in neuroenteric cyst, in كل السيست اللي سويناهم احنا سوينا 4 cyst different studies كل واحد فيها يعني multiple cases and I found it is positive in all these cysts. So it is very interesting and it probably gives you insight about the origin of this cyst. الليترشر مش موجود حقيقة في هذه النقطة، فأنا حبيت أدخل more deep and because we do everything Dr. Ibrahim cases and we have a good number of cases. Sometimes it gets you good insights about new discoveries probably in neuropathology. هذا ال B63 is another marker for it's nuclear stain مش cytoplasmic stain. Another marker for epithelial tissue, especially squamous. So this is, I call it endodermal, enterogenous, neuroenteric. It's all the same tumor or the same terminology. It stands for neuroenteric cyst. Thank you very much.
It wasn't a malignant transformation of any kind.
No.
Malignant transformation is rare.
Yeah.
So this is
4 cases.
4 cases reported in the literature. Yeah. So this is a very rare case. As I mentioned, only 80 cases are reported intracranially. About 23 cases are in front of brainstem. So this is be a very good case for publication for any active energetic resident to actually dig deep and publish it. Post-operative course, he woke up on table, he must wake up on table. We cannot send them to the ICU unless they are awake. And this is the next day MRI. We always do MRI the very next day. So you can see that it is free. No remnant of the tumor or the cyst is there. This is in contrast. Again here, free. And you can see the vertebral artery free. So this is the patient. Eye movements are okay. Facial is okay. And most importantly, hypoglossal is okay in his case. And there's no pyramidal weakness. He came, as I said, in February when we had the snowstorm. So he witnessed the cold weather in Jordan. This is the discharge summary, which is, as you know, detailed, saying everything.
The headache was gone.
Absolutely, yes. Yeah. And we sent him to Dr. Walid Sarhan for post-operative psychological assessment. So there it is, putting a hat on him and wearing his scarf, ready to go to Bahrain. He went back to Bahrain. So that's the end of the case, and thank you. If you have any questions, please. We're open for any comments or questions. Any questions or comments for the international audience?
Yeah. I'm sorry, Doctor, I wasn't prepared for that. Ulrich, do you have any comments or questions?
Actually, no, Dave.
Go ahead, Ulrich. Go ahead. You got it.
Yeah, thanks, John. Thanks. The government is doing that. But my experience with G6PD was when I was at the American University of Beirut. We used to go to hospitals in Sweden, and there they had lots of fields of fava beans, and we had children to the emergency room maybe 5-6 a day when the season is just passing by. And I just learned today about anesthesia and G6PD. It never came to my attention that we should be careful and make attention to this anesthetics. I don't know where is doctor. You know, if you have a child that I tell you he has G6PD and he needs to have tonsillectomy, you worry about it. But this is now probably, I don't know how often other anesthetists know about it and other pediatricians know about it, that they should really make a point about G6 G6PD, which is a very common thing here, and anesthesia. Thank you very much for what I learned today. I want to tell you about your great lecture about how to pass an oral exam. My 6 residents that I sent, they are very thankful to you. Very nice, very informative. But they have to study how to pass.
Okay, if there are no questions.
Well, Dr. Abraham, can you hear me?
Yes.
Can you hear me, Dr. Abraham? Apparently not.